our behavioral health patients that are sitting with us for hours, sometimes days, sometimes weeks, need just as much time and attention as our medical patients.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and I am thrilled to have you back for another episode of Art of Emergency Nursing. Thanks for listening to the podcast. My episode today was with my friend Bill, and while Bill is no longer in the emergency department, you can tell the emergency department is still 100% in his heart. My friend Bill Schuler is a longtime ER nurse. He's an author. He is an advocate for emergency nursing. And he is one of ENA's go-to experts on the topic of workplace violence. You are going to love this episode with my friend, Bill Schuler.
So my name is Bill Schuler, and I'm currently a patient safety specialist. Started out as an emergency nurse, of course, and about 3.5 years ago, I stepped into a patient safety role. I currently help support a hospital system in the Pacific Northwest. I help to cover eight hospitals. And I don't know what else you want to know.
How do you like the safety role?
The safety role is very different. It is challenge. It is a challenge, but I find that it is good. Like emergency nursing work, a lot of tasky things. That's kind of a role. But here, I get to use my brain a lot more, figuring out why things happen, figuring out how things happen per se, and coming at it with a non-judgmental attitude. I mean, I still encounter it when a bad event happens per se. A lot of what I do is working with what we call sentinel events, which are fairly bad patient harm events. And I still get the reaction initially when you hear about them, like, well, how could that happen? But it's like, no, hang on. Let's take a step back a little bit. Let's really look at things and really find out why things happen. Kind of keep a calm, cool head. And probably one of the reasons why I went into patient safety from the emergency department was, I think I had a moment of clarity or insanity, however you want to define it. I realized that there's plenty of us taking care of patients, but there's not a lot of us taking care of the caregiver.
Yeah, that's a good point.
I felt that through this role, I could help support. I could better support caregivers in a time of need. For some caregivers, it's some of the worst times in their career or even in their life. So I thought that maybe taking this role would help me accomplish that a little bit better.
That's a great way. It's a great way to support nurses. And you're right, at a time when they need support probably more than any. So I really
and I do find that, some are grateful for the help, and but still, even after I've heard, through the grapevine after that, fairly quickly after a horrible event, those nurses are not, either they chose to leave or, I don't know some of the reasons why they're not on the unit anymore. I can assume.
I think that's one of the things I found is that oftentimes after a sentinel event, whether it was, they're never intentional, right? I mean, they're always, it's always one of those things where you're like, holy cow, it's, something bad happens. But a lot of times, even if there is no career ramifications per se, a lot of times there's career ramifications, and a lot of times those are self-imposed. And it happens where people will. I've had people who said, "I'm never doing this again."
Yeah. I mean, there's been one person that I've watched kind of grow through the years, and you know, it was purely horrible. She gave great care, yet it wasn't her fault, but the patient actually languished and was waiting for a surgical procedure and couldn't receive it in time and died. And we know that we're like, well, what could I have done differently? If I had only just done this, we second guessed ourselves, and that's normal, right?
Yeah.
But still, awful just to see her go through it. I actually felt, blessed that I had known this person before they became a nurse, especially an emergency nurse. And, it's crushing to see it happen to them. But yet I felt honored that in a weird way, I was able to be there for that nurse.
Yeah.
During that time.
Yeah, what a powerful thing what a powerful position to be in, and a powerful thing to be able to help support people in their time of need. That's really cool.
Yeah.
That's really cool. Do you miss being at the bedside?
There are days where I wish, I'm like, it was so much simpler just to be at the bedside. Bring somebody in my rooms and let me just do the tasky stuff. Let me chat with the patient, get to know them, and do the IV and do all that. And then I remember why I stepped out of the emergency department. It's all of the other stuff.
Yeah.
Some of the lack of support, whether that's real or perceived, to processes. It's like, well, why does the ER have to back up? Why does the ER have to hold everybody? Why does the ER, have to hold people in the hallways? Why can't we look at this through a hospital issue, the whole throughput thing? And, why can't we even out the surgery schedule so, we actually have beds for patients that come through the ER?
Yeah.
The current hospital I'm based out of, it's pretty standard almost every day. We admit about 25% of our ED patients.
Holy cow! That sounds. Yeah. I guess that's probably about average, I would think, but I'm not positive. What the average is.
Yeah, I'm not sure what the average percentage is either, but we're pretty consistent in that. And just within probably the last year, we've had some record volume. And I read the safety report every day, so I know that how often they go on divert, which is fairly common. And yet this hospital here is the second busiest in the state.
Wow.
So,
well, that's pretty busy. So, holy cow. So how long have you been a nurse, Bill?
I've been a nurse since officially, I graduated in December of 2001. My home state is Wisconsin, so I was in the University of Wisconsin system. So I graduated December 2001, officially got my license in 2002. So if I include my nurse externship, it's 19 years.
Wow, that's long. That's a little while.
Yeah, all of that has been emergency up until about 2016. I still consider the ER my home. I still consider, ENA as my professional organization, because out of the other ones I belong to, I think ENA does the most for its members.
Yeah.
My opinion. We do a lot of stuff, and we have a lot of good things out there, a lot of good products, a lot of good courses and classes.
Yeah.
So before I became a nurse, I became an EMT right out of high school. So I got my EMT license in 97. So I did that all through college and nursing school, and even after was the bonus. I considered my EMS experience gave me a leg up kind of on the nursing thing.
I bet. Now, How do you think it went for you starting as a new grad in the ED? It's sometimes a transition that's sometimes tough to make.
I didn't find it that difficult. It was just, it's different than, in the back of a rig. But I think what helped me was I signed up for a private ambulance service as I was going through EMT school. And one of the co-owners was a nurse, an emergency nurse. And so I think with that relationship, she actually helped me get that externship. And then I was hired on after I graduated nursing school.
Yeah.
But I think I had kind of, it wasn't jumping into the, deep end. It was more of, going into the waiting pool and getting into the deep end per se.
Yeah.
So it wasn't that much of a shock that I remember. It is different because you're with patients longer and, patient populations are a little bit different from where the ambulance service was to where I worked in the ED, which was an inner city downtown emergency department.
Yeah.
So,
and what made you decide? And what made you decide to go into nursing?
Well, that's a good question. I think my exposure as a child, I was fairly severely asthmatic as a child. So through many of my developing years, I was in a hospital ED at least once a year, sometimes more. And sometimes I would have to be admitted into the hospital. I remember when some of my early memories are of being in an oxygen tent.
Oh, wow.
Where they had to put ice in the back and things like that. That wasn't fun.
Yeah.
But I think that might have started. And then, of course, the whole, I love lights and siren of the ambulance. That probably, helped spur me into being an EMT. But then as I was going through college, when I started college, I didn't start in nursing. I started in music education. So,
interesting.
Wanted to be a band director.
Oh, okay.
But then I looked at my band director, and I'm like, do I want to do that? Probably not. And then I'm like, well, maybe I'll do pre-med. And so I did like a semester of pre-med. And I'm like, well, let me look at that a little bit closer. How many years of schooling do I have? How much time do I have to myself? Will I be able to separate work and home life?
Yeah.
Like, I don't know. And having been exposed to nursing colleagues while I was at EMT, I think that kind of helped push me over.
Yeah. Tell me about a patient that changed the way you practice.
Excellent question again. Let me see. The one that comes to mind, and this was not too long before I left. I guess I don't like using the term I left the ED because I don't feel I've left it, right? I haven't really left.
It's like the mafia. You never really leave.
Once you're in, you're in.
Yeah.
I feel I could easily step back in it, tomorrow. But there's one patient that, so I had, by some grace, I had finally made it to day shift. And so I took over this patient who, in report, they said that she had assaulted, I don't know if the patient had a sitter or assaulted the other nurse, but a night shift. But, she had been in restraint. So when I received her, she was still in restraints, but she was sleeping. So I took her out. And later in the morning, when I came back to round, we talked about it. I said, I heard last night that you had hit at somebody or you hit somebody. And, I just want to kind of understand why that happened or how that happened. And she, what I understood was that it had been a busy night, of course. And as, often sometimes happens in the emergency department, those that are, medically stable, might get pushed to the back burner per se.
Yeah.
and we don't maybe check on them as often as we should. And so this is probably one of those nights. And she didn't, I don't remember what she said she wanted, but she said, why I did it was the only way you were going to pay attention to me. And I'm like, violence, of course, is not acceptable, but for some reason, she thought it was the only way for staff to pay attention to her.
Yeah.
And so I'm like, and so in the moment, I remember, I'm like, you know what? That makes sense.
Yeah.
It makes sense to me.
Yeah. Like I get it, but it's
right. It's like, I get it, especially if nobody's seen you or poked their head in for 4 hours.
Yeah.
Yeah. So I think kind of what that made me think of is like, no, and I had to advocate for it a couple times after that. Our behavioral health patients that are sitting with us for hours, sometimes days, sometimes weeks, need just as much time and attention as our medical patients.
Yeah.
And I get it. Sometimes we might have that same patient for days on end. You get to know them, but it still doesn't remove us from popping our head in, or even if we have a moment, sitting down to chat with them. Because at least where I used to work, that room, our psychiatric certified room, had no windows in it. So,
yeah, that's one of the things I've found in working in a facility where we ended up sitting on psych patients for days. For days, we keep these people in there, and we do such a poor job of taking care of those patients. I mean, we just don't. We medicate them when they start acting up, and then it's just wait. I mean, there's we go, oh yeah, we got to order a tray for so and so. We got to get her, make sure she gets fed 3 times a day. And, you're like basically sit in the room, watch TV, and we're going to have somebody stare at you for the next 12 hours to make sure that you're safe. And all that, and they're already crazy. And then we make them even more crazy.
Well, and I think how I would kind of phrase it is with patients is like, look, I understand this is not ideal. I know you would rather be somewhere else. And actually, I would prefer if you weren't here either. I mean, that's not probably the way I would say it, but it's like, I know you would rather be somewhere else. This is not ideal.
Yeah.
Ideally, you would be somewhere where they can address your issue appropriately, but there's, we don't have space here. The place that we want to send you to doesn't have an open bed yet. So while you're here, I'm going to make sure that you're warm, you're comfortable, you're fed, but I want you to let me know if anything is happening. So if you're starting to get anxious or if you need anything, I want you to let me know. But it's just acknowledging. I think part of it is just acknowledging that, this is kind of a sucky situation all around.
Yeah.
And, acknowledging that with them, I think just helps.
It goes a long way. It goes a really long way.
Because, I mean, we did have some people there for weeks.
That's crazy. That's crazy. It's. I mean, we do the emergency department is such a poor place for a behavioral health patient. I mean, we just don't do a good job with them. We do a good job at the chronic stabilization, but then that's it. Like, we're not good at long-term care.
Yeah.
So that makes it tough.
I like to say that, before I stepped out, I was starting to get good, at caring for psychiatric patients where typically I would, make sure I interact with a social worker after I know the social worker has assessed them that day. And so, what are you thinking? What's our plan? And even, to the point where it's like, well, let's have a powwow with the physician. I know they're still going to be here for a couple more days, but is there anything we need to change or what's the status? Because, sometimes I saw that it was kind of disjointed. Docs doing their own thing. I'm kind of doing my own thing. Social workers doing, their own thing, but we need to get together.
Yeah, we're not all on the same page.
Right.
That's sometimes too bad. So, Tell me about a time that you made a medication error or a care error.
That's fun. Oh my goodness. My first one that I remember was that I confused lactulose with K-oxalate. I remembered, I'm like, I'm not sure which one I need to give, but the patient had hepatic encephalitis. So of course it was lactulose and it was K-oxalate. And all I remembered with the frame of mind I was in was that I need to give them some, it comes in a cup and I need them to drink it. So I think what I did was I looked for it because it had to come up from pharmacy. And probably because I couldn't find the lactulose in our drop-off bin, there was a K-oxalate. So I'm like, this must be the one. So I gave it. Yeah. I gave it, and then it was a few days later where the interim manager called me into the office, like, you gave the wrong medication. I'm like, oh, I did? And, she went through, it was like, fortunately the patient's, potassium didn't really drop much, so it was fine. But I also remember at that point, I was burned out for the first time. My attitude to it was, so what?
Yeah.
Big deal. I didn't harm anybody.
Fine, so it's not a big deal. And you're like, no.
So, yeah, I just remember my frame of mind is like, okay, no big deal. So, and, I got, I got my counseling, from the master with that, but that's probably my first one that I remember.
Do you think the burnout had something to do with that? Do you think you just didn't care?
Yes.
Wow.
I would say definitely yes.
It takes...
Yeah. Like I don't know why it's taken so long to give me a copy. The order's been through, so I don't know why it's up here. I think the doctor meant K-oxalate instead of lactulose, so I'm just gonna, give this one instead. And I would mention that probably there was a knowledge error too. What is lactulose used for versus what is K-oxalate used? And I didn't bother to stop and think about it closer. Which, of course, I own.
It takes a lot to admit that and admit that to yourself of, hey, you know what? I probably wasn't in the best frame of mind and I just didn't give the care that I should have gave. So.
Yeah, and I've been burned out at least a couple times. I'll identify with, but that was the first.
What do you feel when you feel like you're burning out?
For me, burnout feels like it's kind of like how I would describe it. There's better ways to do things, and I'd like to make change for the positive, for the better, but I'm going up against all this stuff. And then sometimes when you start talking about it and you want to do it, then sometimes you get a bit of backlash with that. This is not a new concept of overcrowding in the ED, but yet nothing's happening with it. And so I think I get to the point where I feel powerless to make positive change. And, I'm sure, you come to work, you're like, okay, it's all the same thing, right? Same type of patient. We get plenty of abdominal pains, which could be a myriad of stuff. We have, this time we have, psych patients overflowing into the medical. And it's like, you're like, someday we're going to have so many behavioral health patients boarding in our ER that we're not going to have any room to take care for a medical patient, and a medical patient is going to die. Or you're in triage and it's like, you're the one nurse in triage and there's 20 odd patients sitting in your waiting room, which for the ER I used to work at was a lot, and you're trying to do the best you can, but there seems to be no more help. And you realize that this is not good care. What I'm doing is just surviving, and the patients are getting the minimal, and they deserve much better. And in a roundabout way,
absolutely,
we as nurses deserve much better. And so I think that's kind of where my mind frame goes when I've been burnt out. Is I'm going to throw up my hands and just be like, look, I'm going to do something else then. And I would say, if you think about going somewhere else, that doesn't necessarily fix the problem, because you're probably walking into the same situation. Maybe just with different people and different doctors and players.
I think one of the things I find is I think that sometimes just a change, even a little bit of a change, even though the grass is no greener usually, and it still needs to be watered. Sometimes a little change sometimes helps. Sometimes maybe a little bit better fit. But it's hard. Yeah. I mean, ER nurses every day are getting their ass kicked. They're working hard. They're working hard for their money. They're overworked, underappreciated, understaffed. But it's.
Kevin, do you think that? Well, it'd be interesting to maybe solicit some feedback from the listeners to this podcast about, let's say you have changed, facilities or ERs. Like, how long did that last before?
How long did it last for you?
You got burnt out again.
When you said you felt burnt out a couple times. Was it a season? Was it how long did it take you to kind of get back to where you're like, and what did it take to get back there to where you're like, oh, okay, this is okay. I'm doing all right. What did it take for you? Because you're right. I think it'd be interesting to hear people's stories of, and see kind of if there's a trend of what does it take. But what did it take for you?
Well, like usually, I'd have to say for myself as of late, I maybe go through a cycle every 3 or 4 years, where the first time I was burned out, I said, I need a change. I need a total different focus. So what I did was I became, and this was on a weird whim, I was searching Craigslist and I found a job ad for a medical weight loss clinic looking for a nurse. And so I'm like, what the hey? And so I interviewed kind of on a whim, and lo and behold, I got it. And the nice thing about that was the physicians that were helping that actually founded this type of weight loss program were emergency physicians. And so we had this, it clicked right away. And I did that. So that was a big change where I had to learn something new. I'm out of my element. Yeah. I'm kind of out of my expertise. So, had to learn their program, and me being curious, I look at the science behind some of this, a lot of this stuff. But I did that for a couple years. The business started out strong, and then it was about 2008, 2009. So the economy kind of hit, and the business dwindled to the point of I was doing resource, nursing in the ED, and I would travel like 4.5 hours just to make sure I wasn't in the metro area where I live. So I'm like, I've done big hospital. If I want to do ED, I want to do small hospital. And so I work in, critical access hospital here and there. And then my wife got pregnant, and I'm like, I need a more stable job. So I went back into the ED pretty much full time. And I lasted in that role for almost 5 years. And then I switched to patient safety, which is like, again, it's a totally different, it's a mind shift. Granted, I take my experience with me, and it's helped me tremendously in this job. But it's a totally different, totally new. And I think it's it's almost, my brain looks at it like a new challenge. I can devote my energies to a new challenge. And, there is a lot of, what do you call it, intersectionality in patient safety and emergency nursing
sure is.
too.
I'm sure it's, it's because safety is all about what we try to be about in the emergency department. And so many patients that come through start their journey at the emergency department. One of the most powerful exercises I remember going through, we had a patient who died an untimely death. She shouldn't have died. She died an untimely death, and we did an M&M, mortality and morbidity, for it, and said, okay, what was the point that at the like things could have went okay if we would have caught it here, or here. What's the furthest point that if we would have caught it there? She had sepsis and it wasn't caught. You could tell in the documentation, when we looked at the documentation, you tell the nurse was certainly thinking sepsis, but the doctor didn't pick it up. The doctor didn't pick it up or didn't think it was significant enough to be a thing, to be, a problem. And we kind of brought it back. And it was, it comes down to a case of, if we would have just sent this woman to the trauma room when she first came in versus sending her to the cubes, that could have potentially made the difference between either her having a good outcome or not. And looking at all the decision factors that affected that, like, why didn't she go to the cubes? What, did she have the right story for it? Why did she go to the cubes versus why didn't she go to trauma? And, being able to tie it back and look at that, we looked at it closely with patient safety and hand in hand with the emergency physicians, and really tried to kind of walk it back of where was the first failure that could have made the difference between life or death. And it was fascinating. It's fascinating to listen to. If we caught it here, she'd probably be okay. If we got it here, she'd probably be okay. If we got it here, she definitely would have been okay. But we didn't.
With
of course,
a slight degree of uncertainty.
It's all
you would say,
yeah, it's all
could have
theory, right?
Right. Speculation. I mean, it's the whole Swiss cheese thing. We have all these safety behaviors. We have all these safety tools. We have, the electronic medical record to help us with things. We have pharmacy. Some ERs have pharmacies, some don't. Or pharmacists, I should say. We have all these, but there's weaknesses in every single one of them. And for all the robotic, artificial intelligence stuff that we've put in place for safety, they cannot predict all scenarios. So we still have to have humans watching the artificial intelligence,
for sure.
Even.
So, Yep. That's there's always that human factor, and you never know. I mean,
in your analysis of that, was culture? Did culture come up in any of that?
I don't think culture came up as much in that particular case. Now, certainly, I've had some cases where culture has come up. But I don't think culture really played much a factor there. I don't think, other than, I don't know. I mean, that's a good question. I mean, there was a culture there, and certainly, there may have been a factor somewhere, but nothing that I'm immediately seeing as an obvious connection. How often do you find that culture is a factor with the sentinel events that you see, or the areas that you see getting into in patient safety?
I would say it probably is a factor more often than we would like. And I would have to say in my role, it is probably one of the hardest, the most difficult things to call out. Because if you're calling out culture, that's calling out a lot of
everything.
stuff.
It's everything. It's from the top to the bottom.
You're calling out, decisions. Right. You're calling out, well, this was, culture was allowed to fester, and it's not, congruent to patient safety. I think more often it's, people are more willing to look at the decision making, the human error, the human decision making, things. Those seem to be more easier to tackle than
even as big
culture.
as big an issue as those can be, and sometimes they're huge. It's easier than trying to change the culture of an organization. I remember reading once that to change the culture of an organization takes anywhere from 3 to 4 to 5 years, and that's probably being generous.
I would agree with that.
I think everyone's probably worked for an organization that had fantastic culture, and I worked for an organization that has fantastic culture, and I've worked for an organization that had terrible culture, and either one takes a while to change. I mean, it just doesn't. You're not gonna change that overnight, and it sometimes takes multiple people trying it multiple times. I mean, I don't know how many times I've seen an ER director come through and try to change the culture, and they give up because they're just like, I give up. I can't do this anymore. I've tried. They don't want to change. Then I'm not going to make them change. And then they move on. They go find another job, and the next person comes in and has to try to also deal with that culture. So it's I think it's everything. It's so hard to change. Now I want to talk. I nobody would forgive me if I had you on the show and we didn't talk a little bit about workplace violence. You're a bit of an expert on workplace violence. So I have so many questions around workplace violence because it's such a problem that emergency nurses deal with every single day. How big an issue is it?
Well, I think it's bigger than we realize. Even, if you look at the data that's out there by the Bureau of Labor Statistics, and quite often cited as healthcare suffers 4 times the rate of violence than anybody in the private sector. So any other business, healthcare is 4 times. You read out of all the assaults, in healthcare, or in any assault in a workplace, over 50% of those are in healthcare, or even I think one of the latest things is 75%. And that's only from what we have documented. So you got to figure that, the Bureau of Labor Statistics data is only those requiring days away from work. So that means that's a significant injury. Well, what about all the other, assaults that have minor injury or, bruising, or a minor laceration or a cut or a bite, or, so we know that it's vastly underreported, and, we really don't have good data, good data mining, and we just don't have the data to see how extensive the problem is. But I think we can all agree it's much worse than we would probably acknowledge.
Yeah.
But it's not just us in the United States. It's really happening all over the world. If you read some of the studies that come out from different countries, China has a problem. Australia. India, even the Middle Eastern countries, even Africa. Pretty much every continent has a workplace violence problem in healthcare. So it's not just us here in the United States.
I guess that's good to know.
I guess if you want to spin it that way.
I mean, yeah. Sure.
That's a positive note.
Yeah.
I don't know how we could truly find out the breadth of violence that happens in healthcare. One of the things I think about is we could do a much better job if we collected data better, in a better way. We could probably do a better job at looking at what is intentional violence versus what is, unintentional. And I think if those studies were done, we would find that I would say the majority is non-intentional or unintentional violence versus intentional.
I think there certainly is a lot of unintentional. I certainly think there's a lot of unintentional, but I think when I think of workplace violence, I think of more intentional, very intentional, where someone is assaulting a nurse, And I know that's a smaller subset of nurses getting hurt at work. I mean,
Right.
one of the worst injuries I got from a patient was from a patient who had absolutely no clue what she had done to me,
Right.
and didn't even know a little bit.
Mm.
But the one that I think of is the one that very intentionally tried to hurt me.
Yeah. And I don't know if the intentional ones have, worse injuries versus the unintentional. But hey, that's a whole study.
That's a whole study. Don't talk about studies with Lisa Wolf. She'll put you to work.
Oh, I know.
So what can be done to mitigate the effect of violence? What have you seen what's best practice?
Oh, let me see. Well, when you talk about best practice, that's a bit of a sticky subject, at least from what I know. So let's talk about best practice first, and let's talk about what can be done.
Okay.
There's a good document that just came out from the Registered Nurse Association of Ontario, and our own Gordon Gillespie was I believe the co-chair and on that expert panel. So he's the only American on that panel out of a Canadian Nurses Association. Anyway, what they acknowledge right off in the document, which it's true, is that the literature doesn't have, there's no good randomized controlled study on violence interventions in healthcare. You just can't do those studies.
Yeah.
So often what we're left with is, quasi-experimental, observational, qualitative, studies that we have to go off of. And so the strength of the literature is pretty weak.
Yeah.
But what this expert panel looked at and acknowledged, even though the literature is weak, their expert recommendation for some of these things is pretty strong, because the alternative, if you don't do it, can be pretty bad. Let's say you don't have a violence prevention program. Well, how can you inform and give your caregivers the best chance to either prevent or mitigate violence if you don't educate them, right?
Absolutely.
Or you leave them to their own devices and they're getting, whatever training's out there, and it's not, fitting with hospital policy and that. But so that's kind of what best practice is. And, we have to be careful what we think is best practice, because sometimes what's in the literature just doesn't back it up. You talk about metal detectors and things of that nature. It doesn't show that it actually prevents violence per se. It doesn't decrease the number of violent incidences in hospitals. As far as what we can do about it, I think, it's some of the standard things, which are, hospitals should be doing their own risk assessment. And really, the risk assessment shouldn't be just security doing it. It really should be a team that does it, a multidisciplinary team. Because, security looks at certain things, but, an emergency nurse might see, well, what about that? What is that? Or why is it this way? And, they might have a different point of view and have a different questioning attitude. Or it's like, why is it locked that way? Why don't we have a code or a bar scanner or a badge scanner here?
Yeah.
That type of thing. So risk assessment, and based off your risk assessment, looking at, who needs training, who needs what training, how in depth do you need the training? What training do we need? I mean, you and I have, we've talked about the MOAB program before, management of aggressive behavior.
Mm-hmm.
And, we know what's within that program, but I'm sure, some of the listeners have done, the nonviolent crisis intervention, or CPI as it's commonly known. There's many other courses out there. So what do you want in your course? Who needs the training in your hospital? Does it just need to be security and emergency department? and behavioral health? Do they need the full training, which includes self-defense? Do you need self-defense in your training? So that's kind of the standard, but and really keeping up that program. So really, if I had to boil it down, it's like having an assessment, having a workplace violence prevention program, which includes education. But I think where we can probably do better is like data collection, looking at data, and then reevaluating your program. There's another unit for our data. This medical unit has, is a close second to the emergency department with the number of like co-grays or violent events that they're having. Maybe they need some training. Maybe they need the full thing. Or, looking at the data of, and that can help you kind of focus your efforts. So I think I'm kind of spoiled on the West Coast here because Washington State, Oregon, and California have state laws that say hospitals have to have a violence prevention program, which includes education. And the state I'm in, it says you have to teach self-defense. And the law says you can't sanction somebody who uses self-defense appropriately.
Interesting.
So, yeah, I mean, I think we're kind of spoiled on the West Coast because, all of the West Coast here has these similar types of laws. And then, there's only 6 other states that I know of in the United States currently that have some similar type of law.
Yeah. It makes a lot of sense to have something, but the question is what is that something? And I think that any training is better than no training at all. Because I think honestly, like you said, if you leave people to their own devices, well, then you don't know what you're going to get. You may have somebody who's trained in something that might do something that may be completely inappropriate.
Yep.
So
I mean, they could have gone to like a weekend seminar and it's like, well, I learned this technique. And it's like, well, that's a little more expensive than we would like.
Yeah. You're like, that's a fine technique if you're a police officer. Maybe not so much if you're a nurse. What other aspects of workplace violence would you like to talk to the audience about?
Wow, there's a whole gamut. But I don't know, some of the things that have been on my mind lately is, if there are, let's say there are some, initiatives that maybe your hospital or health systems are considering, is really look at, in some instances, the scientific literature can't really offer you support. In some things, it can give you some suggestions, but it's really, I don't know. I would say we need more data out there. I just think of the literature on metal detectors. Of course, sure you're starting to search for metal weapons. Well, you're going to find them. Does that necessarily mean that your violence is going to go down in your hospital? I'm not sure. The literature doesn't say that it does. The couple of studies that I've read, have said that it didn't affect the number of incidences of violence. Because if you think about it, most violence doesn't happen with a weapon per se. It's happening with, with biting, with striking, with kicking, and throwing pee or throwing poop or things like that. Which you don't need a gun for, you don't need a knife for. So, but there's other studies that show that people might feel safer or they like it when a metal detector is there. But there's whole logistical nightmares with staffing metal detectors and things like that. But if you're thinking about dogs or canines in healthcare, there's, from what I can read, you're hard to say whether they actually decrease violence in a hospital. I don't know, because the literature doesn't say anything about it really. And we talk about common term in the literature for learning escape moves or things like that, or breakaway techniques. And most of those studies have been done in the UK, and it's been years. It's been many years since anybody's published about that. But, I would say if you learn some of those techniques, it's like any skill. You need to practice those.
Yeah,
I mean,
for sure.
I know there's plenty of listeners that have learned it once, and that's it.
Yeah.
I mean,
I remember taking my first CPI class. I don't know, probably not exaggerating, probably almost 20 years ago. And I think I've taken it maybe once or twice since then. And not that I was, I'd taken other classes that were different, but I think it's been probably 20 years since I've taken that. But, you take it once at the beginning of your position, beginning your tenure at the hospital, and then you don't revisit it until you go to your next job, typically. And we all know that if you don't do those moves, if you don't use those skills, you lose those skills.
Like a lot of our nursing skills sometimes. Like, I think some of them we've done so long and so often that, we'll never lose that muscle memory. But, I would say for many nurses or healthcare, professionals, that those type of physical skills are very new and very foreign. And I mean, some of it, there's a science behind those. I mean, myself being a martial artist, I understand those. You understand some body mechanics and leverage, and you look at joints and manipulation of joints and locks and things like that. But if we want people to succeed with those or give them the best chance, we should be making sure that they're competent in those skills, which I don't think, going over them and practicing them a couple times every couple years is adequate, which makes me, go on to another thing is, I think we need to look at how we do violence prevention courses and how we plan those in healthcare in the United States, because I don't know, it's not robust enough. And I think if we really wanted to do it right, it's going to take a lot more investment of time and money and personnel. I just think of where could we be if, many hospitals I know have been through the high reliability journey, or, been through HPI or been through HRO. And just think of all the time and effort and that's gone into that to try to change the culture, the safety culture. What if we took as much as that and really put it towards violence prevention? Because really, violence prevention should be an extension of your patient safety journey. When your staff...
Absolutely. I mean, it's
because when your staff are safe, I think your patients are safe, right? If we have safe staffing, we know that violence levels go down. Yeah. So there's some mix between, but we know it's not regulated in most states. So I think that's one of the reasons why we have HR 1309 and Senate Bill 851, those national bills that would make it a federal requirement. OSHA would make it a federal requirement to have pretty much all of any type of healthcare would have to have a violence prevention program.
I think that's a great idea. I didn't know that. Are those bills that are currently up for legislation?
Those are current bills in this legislative session. And, anybody who's listening who went to ENA's Day on the Hill, that was one of our legislative asks this year. But HR 1309, so the House bill has had the most traction. It has the most co-sponsors. And
tell me the name of the bill again.
It's HR 1309, so 1309. And the companion bill in the U.S. Senate is Senate Bill 851 or 851. And you can take a gander. It reads pretty well, but it's very similar to like California, Oregon, and Washington law, where, OSHA, national OSHA would say you need to do your own assessment. You need to have a program. You need to educate your caregivers on violence prevention, including de-escalation and things like that. You have to reevaluate your program. You need to, I think the current language says you need to file a report with OSHA on an annual basis. You need to keep track of all the assaults that happen in the hospital or in the healthcare facility. And you cannot retaliate against somebody reporting violence or even, I think, asking for help. Meaning, I think it's specific in there, like you can't retaliate, an employer can't retaliate against an employee for calling, 911 for somebody who's violent. And
interesting.
Yeah.
Interesting. That's makes a lot of sense. I mean, I can't imagine someone getting pushback for that, but I'm sure it happens.
Yeah, we don't do that. We don't call 911, or we don't press charges against patients. Like, well, please remember that it is a crime, and it's a crime no matter where it happens. And maybe some of these types of cases should go through the legal system, because we might not know if they're truly, under an insanity thing or not, or if they're truly not in their right mind. We can't, we as nurses can't do that. So that's really a legal term, but maybe some of these should go through, the criminal justice system. And people like to say that it's punitive, and that's maybe not where it should be, but I've seen it where it has gotten somebody the appropriate resources that they needed.
Absolutely. Now, one of the things I've found in my own experience and experience at a former position where I was, is whenever we would have an assault, some of the nurses just kind of had that mindset of, oh, this is just part of our job. This is to be expected. And I was always like, absolutely not. You cannot accept this as part of your job.
Mm-hmm.
But then what we'd find when law enforcement was called and law enforcement got involved, they'd be like, dude, you're a nurse. You should expect that this is going to happen.
Mm-hmm.
They had that same attitude.
Yep.
And what I always kind of pushed back with was, well, you're a police officer. Do you expect violence? If he was violent against you, does he get a pass? And they're like, oh, no. You're like, well, then why am I free game?
Right.
So, but so many law enforcement officers were so resistant to pressing charges. So, these states would come up with these bills that say, okay, now it's felony to assault a healthcare worker. That's great. But if nobody's going to actually charge these people with that felony, then what's the point in having that law in the books?
That's a great point. When I presented at the ENA conference, this year in Austin, and we had an international member there who was from Australia, and she's like, "Look, we have like a same law. It's against the law to assault a healthcare provider, but then the magistrate does not prosecute. You have a law, but you don't enforce it."
Yeah, and then it's like, then what's the point in having the law? But I understand, and I understand that's hard to prosecute. I understand that it's hard to prosecute that, and it's hard to press charges when somebody who very well may be mentally ill, for instance.
Right.
But how else are we going to force the hand?
Right.
To make sure that they get the help that they need?
Right. Or
I don't know the answer to that.
Or to make sure that they stay on their treatment regimen, things like that.
Yeah.
This is a fairly large topic. I had the chance to sit down with a deputy district attorney of my county where I live and where I work, and we kind of sat down and we kind of explored this whole thing. And and maybe I don't know, we could reframe it as when we say pressing charges, it really isn't the victim who does that. It's the district attorney who does that.
Okay.
How it typically goes, and listeners of this podcast can correct me if I'm wrong.
Your mileage may vary based on your location.
Right. But it starts with calling law enforcement, and if and the first hurdle would be to get the law enforcement officer to take your report. And
yes,
if you get pushback, I would say that is a good time for either your emergency department leadership or even your hospital leadership to have a conversation with your chief of police or your local sheriff. I think it's a good time to have a sit down and be like, look, we have this problem here, and explain, here's how wide of a problem it is. And even, that's a good time to talk about statistics. Look, we get assaulted a lot. And I bet you what you'll find is some people are like, I never knew it was that bad. But I think that's a first step if you get resistance from law enforcement, is to actually start going up their chain of command and start having those conversations. Invite them in. And I think having a good working relationship between healthcare and your local law enforcement is the first step.
It's critical.
So going back to having the law enforcement officer take a report, that report, of course, is reviewed by the district attorney, and they are the ones really who make the decision of whether it's a prosecutable crime or not. The feedback I got from the deputy district attorney who I talked to was, you actually really need to be injured. Like, you need a broken bone, you need a significant laceration that needed to be sewn up, things like that, in order for it to start as a misdemeanor in this state. He's like, this is just kind of the way, this state has, or my state has some minimum, they have a kind of like a sentencing grid. Or, if it's this crime, you get this sentence, or they have these guidelines. Anyway. But really, it is up to the district attorney or the deputy district attorney to determine whether a crime, is prosecutable, or whether they want to put their efforts through or not. Now, I don't know if across the rest of the country, but another tidbit is that, at least in my county, the district attorney is an elected person.
Yeah.
So, I mean, you could go that route too. Or you could consider that route too if you needed some influence. But we talked about, it's like, it's not a felony in this state. And he's like, I get it. And if in this state we wanted to make it a felony, we would be on equal footing as taxi drivers. It's a felony to assault a taxi driver. It's a felony to assault a public transportation operator while that vehicle is moving. It is a felony to assault EMS, EMT while they're doing the work. And from what I know, they might not even be actively prosecuting for those. But who knows? I mean, we've tried a couple times to get felony legislation, and we're still working on it.
It seems like one of the first things you need to know is what you don't know. And that's, just doing the data collection.
Yeah.
Seems like that's a good first start, because that's what you can then take to your chief of police, your local sheriff, and say, here's how many times we've been assaulted in the last year.
Mm-hmm. And when I reached out to him, and I just said, I want to talk with you about it. He's like, is there a specific case I should know about? And I'm like,
you're like, no.
But I guess I'll keep you updated if I know of them, right? But in my role, I'm a little bit removed from that. But I think the conversation was helpful, and we actually, I belong to my system, or actually my region that has 8 hospitals. I belong to that workplace violence steering committee. I'm a member on that, as well as all the general committee and some work groups, but I'm also the hospital where I'm based out of. I'm on their workplace violence committee too. And we actually brought in that deputy district attorney to speak with our committee. and it was a great conversation where, other members were throwing questions. And another benefit is we have a law enforcement officer on our workplace violence.
Nice.
And I think I would say, think of that, think outside the box a little bit like that.
Yeah. Boy, I would love to get to the point where we're actually collecting this data became mandatory. Because if you mandate something, then it actually gets done.
Right.
Because right now, it's one of those that, we asked at one of the EDs that I worked at, we asked people to start collecting data of, hey, when did you get assaulted? When did this happen? And what was the result? And we got, some anecdotal data, but then, you'd tell somebody, I remember as a supervisor saying, hey, you got assaulted. I need you to do the little quick 1-sheet report. They're like, why bother? Nobody ever looks at those things. I'm like, that's not true. We look at them all the time, but we don't know what we don't know if you don't tell us.
Right.
So.
Yeah. And I mean, my advice is if you're of that mindset, it's like, well, why bother? Why should I report? Because nobody follows up with me. I don't hear, kind of the outcome. I don't know if my manager has even looked at it, things like that. And I get it. I mean, that's the reasons why we don't report is you can find it in the literature a lot. And there's many reasons, but I would say simply do it anyway.
Yeah.
Do it anyway.
Yeah,
take the time, back when I was in the ED, if it happened, I would, even if I was a spectator that saw it or helped, I didn't receive the violence, I wasn't assaulted per se, I would report it, not only to the person it happened to, but if you witnessed it, I would say report it. And, one of the things I've seen is one of the problems is, so you fill out a workplace violence report. Okay. Security comes and responds and they have their own reporting system.
Yeah.
And then let's say it's like, I don't know, people have common term as a code gray, right?
Yep.
Well, maybe that gets reported a different way too. So then how do you take all these different reports from different people and merge them into one thing? Or, that's a whole logistic problem.
Or pull that data out. Yeah, somehow. Yeah, no, you're absolutely right. It's a big topic. So before I let you go, I got to ask you the tough question. That's a question called 3 things. Give me 3 things an emergency nurse should remember and 3 things an emergency nurse should just go ahead and forget.
Well, let's see. 3 things a nurse should remember. I would say use your resources that you have, especially if you think you know something. I would say double check or ask a peer. Because I've seen it often where we assume something is the way it is and it's correct, but in fact, things might have changed and it's not. So reach out to your resources, whether you need that drug book to look up a drug, even though you've given it multiple times, or you've given a certain medication, many different times and you think you know it. I would just caution, have that questioning attitude and don't be afraid to use those resources. Because I think it could save your bacon.
Absolutely. Absolutely.
And I would say, on that, to remember is to, not only watch out for your own practice, but watch, maybe keep a gentle eye out for your colleague. I don't know if you've ever, watched somebody and be like, oh, they're about to make a mistake. I'm just going to watch them, do it, see if they catch it. I would say just remember to be a good wingman.
Yeah.
If you would want somebody to intervene for you, how about you do it for your colleague?
Absolutely. Absolutely. I think being a good wingman is a good way to put it, because we all need our wingmen. When you watch someone do something, someone do something, you're like, you've never done this before, have you? And they're like, no, I'm really nervous. I had that happen recently where we were doing a code and I asked this young lady, I said, okay, get ready. She was on the code team that day to be the compressor. And and she had this like sick look on her face. And she's like, I'm like, have you ever done this before? She goes, no. And I go, that's fine. I go, it's just like in class, only it's going to, you're going to have to push hard, push fast. I go, I'll tell you faster. I'll tell you slower. I'll tell you harder. I'll tell you softer. I'll give you the direction and just keep going the way you're doing it once we get there. And she did. And like the whole time I was just kind of standing there and I had my hand touching her and I'm like, you got this. 1, 2, 3, 4, 5, a little faster, 6, 7, a little harder, push harder. Don't forget to let the chest recoil. And, just kind of coaching her a little bit and she got through it like a champ. But, just witnessing and realizing that she may need a little coaching here, and being a good wingman's critical for ER nurses.
Yeah, I would say to add on to that, it's, also have be receptive to feedback and not be like, well, who are you to tell me what to do and things like that. It's, it's one thing to give feedback, but I think that maybe the more harder thing is to receive feedback. And
absolutely,
I think that goes into, that's one of the basics of a safety culture and things like that. And I think, what ties it all together is, I would say, remember the golden rule. Do unto others as you would have them do unto you. If you're having a bad day, how would you want others to treat you? If you made a mistake, how would you want others to treat you?
Yep.
Are we compassionate with each other? Are we understanding? And, we have this whole thing with bullying. I think if we remembered that rule and actually practiced it and lived it, maybe it wouldn't be so bad.
Yeah, you're right. You're absolutely right. So, 3 things to forget.
3 things to forget. Now, I've heard on your podcast of, people saying, you really need to know your stuff. And I would say, like I said, a nurse should remember to use their resources. I would say forget relying on your brain. If anything, your brain will fail you. If anything, we know is that we are human beings, and we feel all the time, and we will forget things.
Yeah.
So I would say if it's like you don't have all that memorized, that type of thing, I'd be like, well, I think the smarter thing is to know where your resources are.
Absolutely.
And to use those. Another thing I would say to forget is maybe learn to, and sometimes, it's probably harder said than done, but learn to leave work at work. I think that's one of the good things about emergency nursing is we typically can leave work at work.
Yeah. But
I think it does follow us home. And however you can learn to forget the stress of that day, I think it's easy to say, let it roll off your back. Like,
it's only that easy.
Like a duck or hop. It's probably not that easy, but like how I liken it to, and this is going to sound so nerdy and I apologize, but when I go to martial arts class, as soon as I enter the door, I have to bow and I have to announce to the room that I'm there. I have to say, hello, sir, hello, ma'am. But in that bow, as I've been instructed, is whatever is happening outside of, this training area, you leave outside because I'm supposed to be fully present when I'm training. So I don't know if there's a way. It's a geeky kind of comparison, but if there's a way that I've heard some people, kind of meditate or they have a process before they go home or even in their car that they kind of remove the mental stress and maybe even the physical stress before they go back to their personal lives.
Yeah.
And then the last thing I would say a nurse should forget wearing that stethoscope around your neck.
Why?
It does not need to be there.
Why?
Why?
Why would you?
Well,
Why?
there's many.
But it looks cool, Bill. Come on.
It looks
How many
cool.
other people
Yeah,
know I'm a
sure.
nurse?
Well, that's a doctor's stethoscope.
Oh, that's right. Sorry, I forgot.
I would say, you can probably Google. There's incidences where nurses have been strangled with their own stethoscope. It's a perfect tool for that. Once somebody would wrap it around your neck, good luck getting out of that. I mean, Dr. Z-Dog MD interviewed a male nurse who had that happen, where the person, was pulling on his stethoscope so hard that it broke it in half. I mean, if you think of some of those Littmans, that takes a lot of force.
Yeah.
I know it's tradition. I know you see it in every picture, but I don't know. Our neck shouldn't be a tool for another tool.
Yeah.
And, how often do you guys wash your stethoscope after every patient encounter?
That's a good point.
And, I either put it in a pocket or they make holsters for those. I know, some of you have experienced those. And I know it gets caught on things, but I would rather have it on my hip than around my neck.
Yeah. Absolutely.
And it can dangle and stuff.
Yeah.
Fall off on a floor. I would just say, forget wearing that. Forget that whole stereotype. I think that stereotype probably needs to go away.
Well, I can't thank my friend Bill enough for being with me today on the podcast. It was a great episode. I hope you enjoyed it. I just want to remind you, if you haven't done so already, please leave a rating and review. Let other folks know what you think of the show. That's what's going to help that's what's going to help the show get some additional listeners and give other nurses just like you a place to hear people just like you. So until next time, who knows who will be the next interview? Maybe it'll be you. Have a great shift.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.